Yeah, thank you very much for having me along. It's good to be here. I just wanted to go over some of the issues around child lung health in the resource limited setting. So mainly we'd be focusing on child pneumonia and something on the impact of HIV and child TB. So please stop and ask questions as we go along. As a clinician who goes and works in a high burden setting, as a pediatrician trained in Australia who then goes and works in a completely different type of high burden setting, you recognise that if you need to move away from the bedside and get more engaged in broader public health issues. And I just wanted to characterise what I think is the sort of perspective that I've learnt is that in the resource-rich setting such as Australia, in terms of improving child health, the focus is very much now on the individual and on the benefit of getting the best possible outcome. And of course that's what we want in every context, but it's often quite complicated. It's often quite expensive type of medicine. We're moving the boundaries, if you like, up to the 99, trying to move up to the 99.9%. And of course everything's relevant to the local priorities and social determinants. In the resource poor setting, there's an issue of cost and there's an issue of limitations of what you can achieve because of the problems of resources and cost. And so focusing just on the best for every particular individual can really not be the best way forward, in the sense that if you can then focus more on the bigger picture, the bigger burden of disease in children, the things that you can move forward without a great deal of cost, if you like, keeping it simple, moving it from the 85% to 95% is the sort of focus that you learn and start to try and address in that sort of context. So just to start in putting it into perspective, the good news is that there are many reasons why child mortality has been falling over the last 2 decades. There's been big advances in child survival globally. And this is an average for the world. These sort of numbers here, average globally for under 5 child mortality, has come down dramatically over the last few decades. Less so of neonatal mortality. And in a country such as where I worked, which is Malawi, in 1995 it was more like around 250, and now it's come down to around 80. And these are very impressive gains in child survival. Anyone think of some of the reasons why we might have moved forward?
Because of the institutional delivery?
What's that?
Institutional delivery?
Institutional. No, I wouldn't say that. Vaccines, particularly vaccines such as measles and pertussis, have made a huge difference. And we've now got vaccines against the common bacteria of pneumonia, Haemophilus vaccine, pneumococcal vaccine coming in.
Now the pentavalent.
And the pentavalent, yeah.
Would you say clean water has had a big part in
Clean water, improving sanitation. These are some of the things that have definitely made an impact. But I think also we have to always recognise the importance of the social determinants in child health. There's been great gains made, I think, because of improved socioeconomic status, but particularly even in countries where there's been that are still poor, factors such as maternal health and maternal literacy are very important factors for improving child health. So as things improve, we also need to keep looking to find what are the common causes of death now, as we're getting down to, let's say, 100 per 1,000 live births. What still are the common causes that we need to be dealing with? Because immunisation is now causes such as measles are not as prevalent as they used to be. We don't need to be focusing so much on measles-related deaths now, but still we have to focus on pneumonia. So you can see that these are the sort of pie charts that are put out by the Lancet series of the global burden of disease in children and the causes of death. And you'll see that the mortality has fallen, for example, from around 12 million deaths in 1993 to around 7 million in more recent estimates. And the pattern has changed slightly, so preventable diseases such as measles and improvements in the management of diarrhea with ORS and clean water, etc., has changed the pattern slightly. But still the commonest single cause of death in children worldwide, there it was called acute respiratory disease, here it's called pneumonia. Pneumonia is still the single commonest cause of death in children worldwide.
Excuse me.
Yep.
If you go back to the previous slide.
Yep.
So is the pattern universal, or are there parts of the world where diarrhea is a more common cause and others pneumonia is a more common cause?
Yeah, so that's certainly true. This is global data, and but there are variations within the region. If for example, diarrhea is a greater proportion of the burden in southern Asia, particularly, where they have the cholera outbreaks, etc. In Africa, it's more pneumonia and malaria take the bigger chunk. So I just wanted to emphasise that we do often think about, we need to always think in child health about the impact of social determinants and socioeconomic status. And there's definitely a clear relationship, as you can see here, between national income per capita, a measure of economic status, in relation to infant mortality. But even within that, there are variations. So, for example, a country such as Sri Lanka is not particularly high up in terms of economic status, but it has a lower infant mortality rate than quite a few countries that are a good deal more wealthy. And it's about equitable distribution, and it's about issues such as maternal literacy. So maternal literacy, female literacy, for example, is high in that particular setting. And so Sri Lanka has, even though it has fairly similar socio-economic indicators as its neighbours in Southern Asian region, it has very high levels of female literacy compared to those others, and these types of things make a big impact on child mortality. So I'll move away now from the broader issues. It's certainly true that in terms of child pneumonia, which is the major cause of death, the high impact countries are in particularly sub-Saharan Africa and the South Asia, Southeast Asian region. In terms of episodes, incidents of clinical pneumonia, these are the major regions of the world. They contribute to a large proportion of the deaths globally due to pneumonia. So, what are the risk factors for child pneumonia? Well, in terms of getting sick with pneumonia and in terms of dying from pneumonia, age is a very important risk factor. The youngest children are the greatest at risk. They haven't been exposed to these pathogens before. Their immune system is not primed, but they have little chests with little airways that easily get blocked up, and they're just not able to deal with chest infections. So age is a very important risk factor for both pneumonia, which is lower respiratory tract infection, but also for death. If you're not immunised against these types of diseases, clearly you're going to be at risk of developing pneumonia. And nutrition, even prenatal nutrition resulting in low birth weight, or nutrition postnatally and malnutrition, these are very important risk factors. the socio-economic related ones, including indoor air pollution. In high altitude settings, particularly where it's cold, people may spend a lot of time around open fires or cooking in that particular context, such as the highlands of Papua New Guinea or Guatemala. And studies show that these children exposed to that indoor air pollution have a much higher risk of respiratory disease and severe respiratory disease. And then of course there's underlying disease, and particularly HIV has had a major impact on child pneumonia. So just to give you a sense of the, to try and quantify some of the impact of those risk factors, this is just some data from some studies we did in Malawi in children with severe pneumonia. And you can see that pneumonia in that context of children with severe pneumonia has a high case fatality rate. You know, that's 14% of children are dying in hospital with pneumonia. That's a high case fatality rate. Impact of age. You can see very clearly that the particular at-risk group are infants. The severity of disease obviously is associated with pneumonia, and what's important to recognise is the children with low oxygen in their blood, hypoxia, because of the severity of their pneumonia, they have low oxygen in their blood. If you've got a saturation of oxygen in your blood of less than 90%, you've got hypoxia. That's associated with death as well, as you'd expect. And you can see here an example of the impact of HIV. HIV with severe pneumonia, much greater risk factors for death. So these are just to illustrate some of these important risk factors. And one of the challenges that for pneumonia is that we use a term called pneumonia. And pneumonia, all it really means is that you have an infection in your lungs. Now, that infection can be due to a huge range of pathogens, bugs. And we know from studies that were done quite some time ago now, back in the 80s, that important causes of pneumonia, bacterial pneumonia, are these sorts of pathogens, which you don't have to recognise. Just remember, of course, I'm not going to go into detail there. And then the other half are due to viruses. Half due to bacteria, this is in high mortality settings, half due to viruses. And there was limited data there from HIV settings because this was before the time of HIV. And they didn't investigate for the contribution of tuberculosis in this setting because it was more difficult to do for diagnosis. But just what I want to make a few points is that we're trying to always come up with guidelines to inform practice, say from WHO, that are global, but the world is incredibly different. And in the high mortality setting, where there's poor nutrition, poor social determinants, these bacteria are more likely to be the cause compared to viruses as a proportion. And the problem there is that it's bacterial pneumonia that is often fatal. Viruses cause a lot of respiratory disease, and you can get certainly lower respiratory tract infections, but these are usually not fatal. And what happens is that as socioeconomic indicators improve, and we've noticed this over many decades, that the shift goes that you're still getting lots of children coming to hospital with lower respiratory tract infections, but in a situation such as mine in Melbourne, Australia, is that this group here is almost 98%. Most of the children coming into hospital have viral infections. And sometimes they need oxygen, they need looking after, but they rarely die. These are rare, and they're protected against viruses that can cause death, such as measles. Whereas in the high mortality setting, it's more likely that it's bacterial, and it's the bacterial ones that, if they're not treated, will be fatal. So they need antibiotics. So WHO's type of approach or response is to recognise the fact that in all the children who have pneumonia, most of them will be able to be treated with antibiotics at home. But there are a small group that have very severe disease and should be in hospital because they need antibiotics given as injections and because they need oxygen. And the challenge to recognise is that it's these group that make up the greatest numbers of deaths, and these group that you can manage at home with antibiotics because they're not that sick, really contribute very little to the numbers of deaths. I haven't illustrated that very well, but I think you get the picture. So the early studies, as I said, in the 80s identified that most of these fatal cases were actually due to bacteria. And so that's the focus of treatment to reduce deaths due to pneumonia. Does that make sense? Yep. And so the case definitions to help health workers, okay, the child comes in with pneumonia. He's just got fast breathing, but that's all. You count the respiratory rate, he's breathing fast, but he's otherwise okay. He can have some antibiotics, he can go home. Because he'll get better with antibiotics, he can be managed at home. And that's the vast majority of cases. But if they're struggling to breathe and they've got chest indrawing, these sorts of things are simple clinical signs that anybody can do by just looking at the chest. That will determine that this child actually probably needs to be in hospital. And then if they have any danger signs and they're not feeding and they look tired and weak and sick, very distressed, then of course this might need oxygen as well. And it's those sort of simple approaches which have been very successful in helping reduce the burden of disease for pneumonia. The numbers of deaths for pneumonia. Of course, there is still the problem of access. Some of these children never get to the hospital and they die before they can get to the hospital, and that does count for large numbers of pneumonia deaths that can't quantify particularly well. But the real aim of the whole approach to looking after these children is just to stratify by severity, which then determines how you treat. Whether you have antibiotics by injection and oxygen, antibiotics in hospital, or just go home on oral antibiotics. And the other aim of it is that you guys will know very well that the biggest group with respiratory infections are those who have colds. They have a cough and a runny nose, but they don't have pneumonia. And the mum comes in, my child's coughing. And what we're trying to do there is saying, well, your child doesn't have fast breathing, your child doesn't have infection in the lungs, it only has an infection in the upper airways. Your child does not need antibiotics to try and reduce, and that is by far the largest group of all that come in with respiratory. You know, in many settings, children of this sort of age can have, those of you who have been parents would recognise, can have 3 or 4 respiratory infections every year. And most of the time they're not pneumonia. Most of the time, more than 80% of the time, they're just an upper respiratory tract infection. So we have to help clinicians. I think what we work around is identifying the ones that don't have pneumonia, which is the majority, and don't need unnecessary antibiotics, and then determining those that do need antibiotics, whether they can be treated at home or hospital. I'm just dragging that out, but it's a simple approach, but I think it's important about how the way we think about managing pneumonia. So what we did in Malawi was we applied that to 25 district government hospitals over a 5-year period. This was a project that was housed within the Ministry of Health. And just by doing those basics and doing them well, but also making sure the hospital had the antibiotics and the oxygen. Of course, there was some training of the health in a stepwise way. We rolled it out over 25 different district government hospitals. And over those 5 years involved more than 47,000 children with severe, very severe pneumonia. Just doing those things that we know we should be doing and doing it well, there was a reduction in mortality over that period of time. And that's been sustained even further looking at more recent analysis up until around 2010. And it's not just due to doing these things well, there are other things that are improving as well. There's less HIV in children than there in 2010 in Malawi than there was in 2000. So some of the risk factors for death are also not as prominent as they were. But it just demonstrates really doing those basics well, you can make a difference to a very large number of cases of pneumonia. Oxygen is important. I think it has an important role in the management of pneumonia, but it actually has an important role in the management of many diseases or procedures around surgery, anaesthesia, labour, perinatal, children with pneumonia, newborns, adults with lung disease, asthma. Oxygen is a very important tool. I think everyone would agree that the management of respiratory distress requires oxygen. You'd be amazed how little oxygen is out there to treat people who need it. Many facilities actually don't have oxygen available. So I just wanted to stress that in terms of the management of child lung health in a resource-limited setting. We would estimate, we did a review, a group in Melbourne did a review, and you would estimate that each year there's probably 1.5 to 2.7 million cases of child pneumonia who are hypoxic, meaning they have a low oxygen in their blood, who require oxygen presenting to hospitals. And the prevalence of hypoxia in children with pneumonia is around 13%. Now, how do you detect whether a child needs oxygen? There are some clinical signs, such as the lips and tongue are turning blue, which is cyanosis, because they just don't have enough oxygen in their blood. They're starting to go blue. You all recognise that presentation. It's a very poor indicator of hypoxia. In fact, even when they're at very low levels already of oxygen saturation of less than 85%, only 44% have hypoxia. Cyanosis, blue lips, such as this child from Papua New Guinea. And that's the sort of chested drawing I was talking about before, showing distress. And the oxygen saturation in this particular child, using an oximeter, is 66%. And that's extremely low. Less than 90% is hypoxia, 66% associated with a very high risk of death. This child clearly needs oxygen. And the advantage also is that the problem also is that not only do the hospitals not have oxygen, many of them don't still have these simple tools to detect the severity of the oxygen. So oxygen availability is a major problem, and these are just some examples that many places, even if you can detect that the child has a low oxygen, clinically or with what we call pulse oximetry that detects that, there's often oxygen not available to treat that.
Excuse me.
Yeah.
I'd just like to question those statistics. Sierra Leone is one of the poorest countries in Africa. South Africa is the richest. How is it possible that in supply of oxygen they're at exactly the same level?
Yeah, so no, it's a good point. I didn't explain the slide well. I just was sort of making a broad illustration, but it's a good point. This is major district hospitals. Okay? This is actually primary health clinics. So you'd normally expect in any setting that the tertiary hospital will have oxygen. Then you get out to the district hospitals, and then you go further out to the primary healthcare clinics. And the primary healthcare clinics often don't provide any inpatient care, they refer them to the hospital. So this is just saying that the primary healthcare, well-to-do country like South Africa, where they do try and have oxygen even at the primary healthcare setting, it's often not available. But in South Africa, it would be available at all the hospitals, no doubt. Whereas in Sierra Leone, it's a very poor country, as you say, and there's many hospitals where there is no oxygen. Similarly in Laos, and similarly case in Papua New Guinea. So that really meant primary healthcare clinics. So just as an example again of what can be achieved, just doing the basics well, knowing what we should be doing, doing what we know we already should be doing. As an example, a colleague I work with in Melbourne has been working in Papua New Guinea for many years and working with colleagues in Papua New Guinea. What they did was that they implemented at 5 hospitals both pulse oximetry to detect oxygen, low oxygen, and provided oxygen at the same time. So now health workers with child pneumonia, they can detect the low ones with hypoxia, and they can now treat it. So it was a before and after study, including 11,000 children with pneumonia. And in just doing this, they reduced the risk of pneumonia mortality by 35%, by a third. And that was highly significant. And even went on then to show, to do some measures around cost effectiveness, and found that it was pretty much equivalent to the pneumococcal conjugate vaccine in terms of its cost effectiveness and reducing deaths. So oxygen is not very sexy. You won't hear anyone talk about oxygen much at this meeting, but it's obviously a very important treatment in any lung health, severe lung health disease. And I think that's very nice how this study's just shown that by just doing the basics well, you can make important inroads in that as well. And then they were able to scale it up from the 5 hospitals that they started with. The Ministry of Health was convinced that this was an important intervention, and then they scaled it up to another 17 hospitals. And there are now research being done at looking for better ways to provide oxygen for the sickest children with pneumonia. HIV had a major impact on respiratory disease in children. It was caused a much greater increased risk of death, but the commonest disease that HIV-infected children developed was lung disease, pneumonia. And prior to having antiretroviral therapy available, in many settings, about 60-70% of babies infected with HIV would have died by 3 years of age, and the majority by 5 years of age. And in most of those cases, the cause of death would be pneumonia. The problem that HIV also brought was that, as you can see from autopsy studies, these children had died, and then they'd examined the lungs and found out perhaps what was the infection from which they died. It's often difficult to find out what the cause of infection is while the child's alive, because of the problems of getting samples of small children. But this was done from autopsy studies. And you can see that there was a wider range of infections, not just the bacteria we talked about before, but problems such as pneumocystis pneumonia. Pneumocystis is a fungus. Really only people with infants with HIV are particularly susceptible. And then other pathogens were recognised that had previously not been recognised as being important, such as tuberculosis.
Can I just ask a clarification question? So every time you say pneumonia, that includes TB, is any lung infection?
So pneumonia is that's right, let's go back to that. That's a good question. Pneumonia is just the clinical syndrome.
Mm-hmm.
The child has cough and he's got fast breathing and perhaps chest and throat. He's got pneumonia. What's the cause of that pneumonia?
Okay.
Could be a whole range of things, including tuberculosis.
Okay. So I'm just wondering, like, because people say pneumonia all the time, so it's hard to know
Exactly.
what they're referring to. when
Exactly.
they say that. Okay.
Exactly. And I think that's one of the reasons why, even though it's the commonest cause of death in children worldwide, it gets very, very little attention,
Mm-hmm.
particularly from research and also through funders, like global funders. Why? Because it's not a single pathogen. It's much easier to get people's focus in research, or even to invest, if you can say it's HIV, it's malaria, it's TB, but pneumonia, well, yeah, but what's the cause? And it is a challenge in trying to get investment in that particular context. So of course there's a lot of research being done on pneumococcal disease, which is one cause of pneumonia, Streptococcus pneumoniae, and that's an important cause. And now along comes the pneumococcal conjugate vaccine. Have all of you heard about the pneumococcal conjugate vaccine? That's going to be rolled out. That's going to make a big impact on child pneumonia. And there are already large numbers of countries now that just started or will be starting before 2015 in the high burden settings. And it'll make a big impact on reducing the burden of pneumococcal pneumonia. But pneumococcus doesn't only cause pneumonia, it causes meningitis. It's the commonest cause of meningitis worldwide. So it'll reduce dramatically that, which is going to be a fantastic improvement. So pneumocystis is a fungal disease that has got a very, very high mortality. And the important thing to recognise about pneumocystis, and it's a HIV-related infection in infants, recognised in the early stages of the HIV epidemic as a major important cause of severe illness and pneumonia. It is entirely preventable by giving cotrimoxazole preventive therapy to a HIV-exposed infant born to a mother with HIV, and you'll prevent that disease. And so the push in terms of trying to reduce HIV-related pneumonia in infants due to pneumocystis is not so much, in my view, about focusing on improving treatment, because the treatment's very, very poor once they've got the disease. Very high mortality. It's about prevention. It's about prevention and mother-to-child transmission, so that there are less children being born with HIV infection. And those that are born to mothers that are HIV exposed, put them on cotrimoxazole preventive therapy. And pneumocystis then goes away. And that has been one of the really dramatic improvements in the last 10 years in the HIV endemic setting, is there are less children being born with HIV, and they're being managed early with cotrimoxazole preventive therapy, antiretroviral therapy, and this problem of HIV-related pneumonia is much less than it was 10, 15 years ago. You can see the impact of HIV in the days before cotrimoxazole preventive therapy, in the days before early antiretroviral therapy. You see the case fatality rate for the HIV infected versus the uninfected in a whole range of settings, and you can see that it was 6 times greater risk of death if you had pneumonia and HIV. And a lot of those deaths were related to infants who had pneumocystis. Sorry, I must also just mention briefly that another problem which is becoming less and less prevalent is the chronic lung disease. Most children born in an HIV endemic setting would develop lung disease and die before the age of 5. There were some who were infected at the time of delivery, but actually didn't present with their disease until they were around school age, or they had just frequent respiratory disease. And many of these ended up with very, very severe lung disease as adolescents. And even antiretroviral therapy did not, when it came along, was not able to improve this. So there was a large cohort of children with very severe chronic lung disease as a result of HIV. Again, that's now fading away. Many of those have died, but also, again, less children being born with HIV, and those that are being born having less of a disease burden. So what about TB in children? One of the impacts of HIV and I'm still at the moment talking around the problem of HIV, and I think you recognise that along with the HIV epidemic, there was a big increase also in the incidence in the general population of TB. And one of the problems was that, as well in terms of children, is that prior to the HIV epidemic, there wasn't as much TB in the community, and it was generally in older people. With the HIV epidemic, there was more TB in the community, and the age prevalence had shifted to the younger group. And these are often parents of young children. And so that increased the exposure of children to TB. So TB in children has been neglected by TB control programs within the context of TB control generally. Does anybody have any thoughts why children were not given much attention?
Ignorance.
What's that?
Ignorance.
Perhaps it's ignorance, but the focus of TB control globally in the past, up until fairly recently, was about finding the cases who are transmitting disease in the community. Case finding, smear positive disease, treat them, reduce transmission in the community. Do children often have smear positive disease? No. And are they responsible for transmitting when they have TB? Do they usually give it to other people? No. No. So the majority of children with TB are young. And they don't have smear positive disease. And they're not coughing strongly, and when they're coughing, they're not pushing much out there. So if you're putting all your resources and attention into finding the people who are transmitting disease in the community, then you're not going to worry about the children. The approach would be, let's get rid of disease in the adults and it will go away in children, which is true. But while you're still struggling with getting control of TB in the broader community, you're still going to have children coming through getting tuberculosis. So over the last 10 years, there has been more attention being given to child TB. And an important meeting was the first international meeting on child TB was as recent as 2011 in Stockholm. Brought together advocates, children, patients, mothers who'd looked after their kids, a wide range of stakeholders, and that led to this call to action for child TB. So we know that TB in children will be common wherever TB is common generally. It just makes sense. They're in the same community, they're being infected, they'll be developing disease. But we really have not very clear about how common. Why is it so difficult to get the burden of disease estimates? We can do it for HIV, we can do it for malaria. Why is it so hard to get burden of disease estimates for children?
Because diagnosis is difficult.
Exactly, because there's really, Jane was talking earlier about the need for a point of care test for TB. It's particularly difficult for children to confirm that they have TB. So you can say, well, clinically I think this child has TB and it needs to be on TB treatment. But people will look at your data from your country and say, well, yeah, but how many of those were actually really TB? And data, as you guys know very well, accurate data is a very important advocacy tool at getting attention to a problem. And so if you still have a lot of uncertainty around the estimates, it makes it quite a challenge. But I think what we can say is that the burden of TB in children will be highest in countries where the incidence of TB is highest. If they're high burden countries will have the higher proportion of TB that is children, and often in these same populations that have a high incidence of TB, often the age demographics are such that a large proportion of the population are actually children, compared to the low incidence settings such as where I'm from in Australia, where the age demographics are rather different. So you have a high proportion of your population children, you have a lot of transmission in the community, and you also have high prevalence of risk factors, often in some of these settings such as malnutrition or HIV, and so you're going to have a larger burden in this particular setting. And this is why when you do look at data from different countries, if you looked at, for example, Australia, you will find that the proportion of all TB that is children is less than 1%. And that's not to be not unexpected. Whereas in the really high burden settings where TB is out of control, the numbers, the proportion of TB in the country that's children can be as high as 40%. So it can be very, very variable. And this is an important slide to focus on in terms of why we struggle with the problem of TB in children. This is data from showing that the greatest risk for disease is in the young. If a child's infected with TB, the ones who are most likely to develop disease is these age groups here. And they're also more likely to develop severe disseminated disease, by that which we mean the disease, TB can spread from the lungs to the brain, for example, and cause TB meningitis. So this is a very high risk group for disease, as they are for most diseases of childhood. High risk group for disease, and they're a high risk group for mortality, particularly those under 2. So we suspect that quite a lot of these children who are infected with TB, we never really recognise that they have TB, and they die as a child with pneumonia, or as a child with malnutrition, or as a child with HIV, and the statistics are recorded that that's another death due to pneumonia, malnutrition, or HIV. And so the challenge is to try and work out in this context how important is TB in this disease and mortality in these young children.
Can I ask a question?
Yeah.
So why does it spike again from 10 to 15?
Okay, so it's what happens in adolescence. Something happens to us in adolescence. It's not just for TB.
Mm-hmm.
The healthiest age probably of any of our ages is the primary school age child. Once you go into adolescence, you become at risk again of diseases. We don't understand why. We think the hormones do something to the immune system, but we don't really understand why. But it's what normally happens in TB is that the risk of disease goes down quickly in early childhood, goes up a little bit again in adolescence, and then goes down again, and then goes up when you get older, 45, 50. What the HIV epidemic did, it changed that so that it went up in adolescence and then kept going up. And that was the problem. And then there's the issues of HIV. If you're HIV infected and you're pregnant, then that's another increased risk again. So the problem then is really why we struggle getting the numbers, why we struggle making the diagnosis, is really because if the greatest burden of disease falls in this age group, which is what was observed in the first half of the 20th century in the US, before there was any treatment for TB, the greatest burden was particularly high in young children when TB was endemic up in Alaska, for example. Very high burden of disease in these children. But this same group is a diagnostic challenge. I mentioned that again around pneumonia, but also generally, but also TB. Why is it such a diagnostic challenge? It's very hard to get specimens from the lungs of little children. You know, if you've been coughing for a couple of weeks, I'd know what to do. I'd just give you that and say, do you mind going coughing somewhere away from me and providing me with some nice thick sputum? That'd be lovely. But children don't produce that type of sputum. But also it's very hard to get anything like that. And even when they have TB, they don't have it like in an adult where you have a big cavity, and when you're coughing up lots of pus. It doesn't infect them like that. It's just more in the lymph nodes. And so they'd actually, even if you get some sputum, it's often negative when you look down a microscope. So, look, diagnostic challenges for respiratory disease, for lung disease in children, is always difficult to find out exactly what is the cause. That's why we work in clinical syndromes. Pneumonia. We don't really know the cause, but we think because he's got that chest drawing, we're going to treat that with antibiotics. We work in clinical syndromes like wheeze. We think that child's got asthma because he's got those characteristics. You can't prove it, but that's what you generally think. And it's particularly hard for something like TB because you actually need to prove it, if you at all can, to get an accurate diagnosis. But we have to just rely on our clinical skills. So if a child comes in and he's got respiratory disease or malnutrition, and then I can ask those, what important question, what information do I need to know, is has that child been exposed to somebody with TB? That contact history is extremely important in children. So it may seem an obvious thing to say, but the really difficult challenges in terms of making a diagnosis are also the same group of children who have the highest risk of dying from tuberculosis. So in trying to head towards zero deaths in tuberculosis, we have some major challenges in terms of diagnosis. We're still relying for diagnosis on the same tests that we've had for 100 years, the same skills we've had for 100 years. Okay? We've always been able to do clinical assessment. Tuberculin test has been around since about 1905 or something like that. Chest x-rays have been around for more than 100 years. And culture of the TB organism. So we really haven't moved on much at all. And this is really our major barrier to trying to move forward in the future, is the problem of diagnosis. And even in some settings, tests such as the skin test is not often available. We rely heavily on chest x-ray for pulmonary disease, and HIV testing is clearly a new test that needs to be done now in the context of HIV endemic settings in children. So one way that we work with is algorithms to try and work towards improving the accuracy of diagnosis, such as this one that's in the guidelines from Myanmar. And I think these algorithms make sense, where you're trying to get some sputum if you can, and if it's positive, that's fine, but rarely can you get the sputum, or if you do, it's negative. Then you go to rely on other things such as chest x-ray and the persistence of symptoms. These are the simple skills that we rely upon to try and move forward in diagnosis. The chest x-ray, sorry. No, I didn't put a slide in. Chest x-ray is not a fantastic tool either. The quality may be poor, but even when the quality is good, it overlaps with other respiratory disease in children. There is no particular x-ray that says this is definitely TB. It's just another piece of information that might help you, but it's certainly not a very good diagnostic tool for children. So it often ends up being a clinical diagnosis using the information that we can get from examination, from contact. Maybe the chest x-ray can help us. And then TB can spread to other parts of the body in children. It can spread, it can go into the lining between the lungs and the chest wall and cause effusions. It can go to the spine and collapse the spine. Can't really see that well. It can go to the heart, the cavity around the heart, the cavity around the bowel, the peritoneum, to the joints such as the knee, to lymph nodes in the neck, or to spread through the whole body and disseminate, going up into causing meningitis. Some of these forms of TB we call extrapulmonary disease, and these ones are often more straightforward to diagnose. And they're an important part of TB in children because of their risk for disseminating disease, for it spreading to different parts of the body. Are there any questions at all?
Yeah, I have one. You pointed out that female illiteracy is quite a big challenge, and I know in Malawi that's a very serious thing. I don't know, in the 5 years of the study that you conducted, did you propose any strategies maybe to improve awareness of child pneumonia in Malawi?
Improve awareness in the community?
Yes.
No, we didn't do that as part of the project, no. But it is an important part of what the ministry prioritises is, I think you're aware in Malawi they have ongoing health education at most facilities. Mothers have their Road to Health card, and I think pneumonia is often talked about. The challenge, I think, often though for pneumonia is that it's the same with the other bacterial diseases in children, is that children can have a tendency of getting infected and going from looking not particularly sick to being dead within 24, 48 hours. Mm-hmm. And if you have a problem of trying to get access to a service, that's a problem. And I think you know that particularly in newborn babies, but even in young infants, they can go from looking quite well to being dead within 24 hours. Those same infections with us, they can kill us as well, but it would take a lot longer in terms of time. And so that's also a big challenge. And it is important, I think, as you stress, to improve awareness about these causes. But I think you'd agree that mothers in Malawi are aware of fever, malaria, cough, pneumonia. These are the common causes of disease in children. Yeah? That's good. So the other, I'd just like to finish on the other important aspect that this same slide emphasises is this increased risk of developing disease after you've been infected. And if a child's infected at this age with TB, it's almost certainly going to be by somebody in their household. Children of this age don't spend a lot of time out and about, if you know what I mean, in the wider community. So as a Canadians would say, this is
I know what that means.
Yeah. But this group here, their social circle is quite small. So we rely on that information really a lot in our assessment in TB in children. We want to know about contacts because in this particular situation, many of these children who are infected at this age will have been done so by a mother, a grandmother, a father, or the child carer who comes and spends all day with them. Yeah? So you should be able to identify somebody who actually either has TB known or actually has chronic cough and needs to be diagnosed and sorted out. Very important part of how we look at the whole problem of
Does it look
TB.
like a family has any like mother, grandmother, grandfather has TB? That kid is given preventive medicine.
So that's what I was just about. Well done. Yeah. Exactly. So the important thing there, let me just is that if you look at studies of child contacts, such as in the Asian setting, you'll find that a large proportion of children who are contacts of a TB case are infected with TB, meaning having a positive test, and even quite a large proportion already have disease at the time of being screened. And so this is a very important area, we think, in terms of public health implementation. We need to, whenever a person is identified as having TB, smear positive disease, we need to know about the numbers of children in the families. And this knowledge and the potential of this intervention has been known for 50 years. It's in all guidelines internationally and nationally, and it's implemented almost nowhere. So this is a big challenge, is implementation of contact screening. Now, contact screening is not to just identify children who might have disease, it's anybody else in the house who happens to have disease. So it's a form of active case finding. But it's also to identify the young children who are at high risk of disease, so that we can do what? We can give them preventive therapy. You probably hear a lot about isoniazid preventive therapy, and that's been known for a long time, that if you give this group here isoniazid preventive therapy after they've been infected, you will reduce the risk of disease to almost negligible. Okay? So BCG has been effective in reducing this red bar, the disseminated disease in young children, BCG immunisation given at birth, but it's not been very effective against the green bar. But if these children are identified at the time of contact before they develop disease, then, and you give them preventive therapy, you'll reduce the size of this green bar very substantially. Does that make sense? Because what happens is that a child's infected with TB, they won't develop disease. It's not like pneumonia, where the bacteria multiply very quickly. They become infected one day and have severe pneumonia 24 hours later. In TB, they'll be infected, and then there'll be a lag phase before they then start to develop disease. Often 3 to 6 months after they've been infected, most of them within 12 months of being infected, if they develop disease. So there is this lag phase, and that's an opportunity to provide preventive therapy for the well children in that context.
Is IPT available in a liquid form or only in
So it's available in a liquid form, but the availability of it in the most of the TB endemic settings is in the form of a small tablet.
Mm-hmm.
But even that's a challenge. Now that we've switched to what's called a fixed dose combination for the treatment of TB in everybody, children and adults, a fixed dose combination combining the 3 most important TB drugs, countries are procuring that, but in the past they used to have isoniazid because it was one of the drugs for treatment as well. But now they're procuring fixed dose combination. Many countries are forgetting to procure single dose isoniazid. So even if you wanted to implement it, particularly in the non-HIV settings, if you wanted to implement it, it's a struggle because the isoniazid is no longer available. But the preparations are there that children can take. There's not a big issue about them taking it. So this is a potentially very, very effective, very important intervention to reduce the risk of disease in these particular children, and particularly the risk in these young ones who are at risk of severe disease and death. It just doesn't happen. So what we've tried to do is put out there a very simple symptom-based screening approach to contact management. And so the highest risk group, less than 5 years, if they're well, you don't have to send them to a hospital for this assessment. It's just, is the child well? Has he got cough? No. No, he's fine, he's well. Then put them on preventive therapy. If they're symptomatic, could have TB, of course they need to be referred to hospital for further evaluation. But the majority will be well in that household. And if they're more than 5, but not HIV infected, then they don't get isoniazid preventive therapy because the risk of disease in that group is much smaller. Does that make sense? What we're trying to do is to reach these children who are well, they've been in contact with somebody with SME-positive disease, they're under 5, they're at high risk of developing disease, they're still well at the moment, give them preventive therapy, and the majority will not have any further problem. And so this had not previously been evaluated prospectively, but we've done this recently in Indonesia with 12-month follow-up. And you can see what happens is that when you evaluate first up these children in their different age groups, a certain proportion will be symptomatic in both groups, and a greater number will be well in both groups. And of those that were symptomatic, numbers of them will be decided, no, they don't have TB. They were getting better anyway without any treatment for TB, just had antibiotics for cough, etc., and got better. So, and the same in this group here. But you do identify some children in the house who are out there in the community, have not previously been identified, who now are being put on TB treatment. These numbers here, of the 269 contacts, 21 end up on TB treatment. Yeah? And then you follow them up, and none of these children after 12 months, these ones got better, none of these children had further disease at follow-up. 4 who had been well did develop disease at follow-up. What might look surprising is that this is the high-risk group for disease, but none of them developed disease at follow-up. This is the lower risk group, some of them developed disease. And the important thing to recognise is that these children here were given IPT, and you can see that none of them developed disease at follow-up, whereas some of these who don't get IPT did develop disease. So I think it's an effective and a safe, but the important point I guess I want to make is that by making it a symptom-based screening, this doesn't have to happen at a tertiary hospital. This can happen in the community where the DOCS provider, the primary health clinic who's looking after the patient with SMEAR-positive disease, can just start to get some information about the context and start the ball rolling so that you're getting these children at least onto an effective preventive therapy. This is starting to be implemented in just a few settings in just a few countries. That really is the big problem in child TB, is addressing the policy practice gap. We've got no end of documents now, including a roadmap recently published, but we really still have a lot to do in trying to move forward on issues around TB. And it focuses particularly around the diagnosis of the child who presents with TB's symptoms and trying to get that right, and then the child contact who's in a household with TB. These are the two areas that require more attention and more work. And so what we've been trying to champion is getting the child health community to work more closely with national TB programs. You have to recognise that a person with SMEAR-positive disease, an adult with SMEAR-positive disease, will turn up and provide their sputum, and that will be diagnosed, and then they become part of the national TB program data and management and everything. A child who's got TB doesn't present to the national TB program, he presents to the general child health services. They're looked after by the child health workers, the pediatricians. And if they're not sensitised to the issues of thinking about TB in children, and certainly if they're not sensitised to the fact that they should be reporting every child who's treated for TB to the national program, which in many cases they don't, then you've got this disconnect. And so what we're trying to work towards, and this is suggested by the national program folk themselves from about 8 countries, getting the child health community and the national programs to work much more closely together, to support each other, whether it's in training, whether it's in operational research, whether it's in gathering data, and just improving the awareness in the whole child health community about the needs for children with TB. This was recognised, again, I keep going back to the fact that we've known about these things for a long time. And even the fact of what we're trying to do now, getting the child health workers together on TB, this statement was made by one of the pioneers of preventive therapy for children, did the first studies based in New York at the time. There are many contributions which the paediatrician can make to a TB control program. But one of our challenges is to convince people in the field, child health workers, that TB in children is not so difficult. There's a lot of negativism around it, around diagnosis. trying to recognise it, trying to manage it. And I think that's really what we've been working at for some time now, is to try and get everybody engaged in improving the care for children with TB. So just finally, this is what the roadmap was about, which was recently launched. And it was really about being consistent with the Global TB Program strategy in moving forward beyond 2015, which is moving away from the more vertical approach and focusing on smear positive and case detection, working as a national program, and trying reaching out to other health sectors, improving case finding. And other health sectors will include maternal and child health. And roadmap is that document that tries to sort of chart a way forward. And I think so far has been at least successful in bringing in those representing the child health community who previously had no awareness around issues of child TB. So yeah, just to finish, I've talked about the fact that at the background there, for any issues around child health, we should always recognise the importance of social determinants, and that child health will move forward as maternal health will move forward with improved socioeconomic development and literacy in many of these things. In terms of prevention, the pneumococcal conjugate vaccine, because pneumococcus is such an important cause of pneumonia and a cause of death, pneumonia in children, this is going to be a very important intervention over the next few years, where we'll start to see big gains in child pneumonia. We're already making huge gains in terms of the burden of disease of HIV in children, because HIV in children is becoming, new infections in young children is becoming much smaller over these recent years, and there are interventions to reduce the burden of disease. I've talked about the management of hypoxia, a very neglected area in terms of trying to reduce deaths due to pneumonia in children. And then finally, another very neglected area which has huge potential is around the managing the children who are contacts in households with TB. So thank you very much.
Who has questions?
I'd like to know your comment on pneumonia vaccine for infants. But in China, it isn't. It is only recommended, but not compulsory.
Yeah. This is pneumococcal vaccine?
Yeah.
Yeah.
But I don't know why.
I don't know. That would be a national decision. Every country has to make their own decision about whether they want to apply to Gavi, which is the Global Alliance for Vaccine Initiative, to implement pneumococcal conjugate vaccine. The focus has been on particularly high burden countries with pneumococcal pneumonia. So again, sub-Saharan Africa particularly, and some countries such as China, where they've seen incredible changes in socioeconomic, those social determinants that I'm talking about, they're recognising that pneumococcal pneumonia is probably not as common as it used to be. Now, are we going to invest in this vaccine? Do we prioritise this vaccine if we're not sure how big the burden of disease is anymore? Mongolia is doing the same, I know that. They want to actually do some surveillance first before they'll decide that they want that vaccine. There is surveillance in Vietnam and other countries in your region. Because what happens with socioeconomic development is the burden of pneumococcal pneumonia, bacterial pneumonia, will start to go down anyway. And so then do you invest in a big vaccine program? It's not cheap. Yeah, if you're not convinced of your burden of disease. Having said that, pneumococcal vaccine rolled out in countries like the US and Australia has shown marked reductions in hospitalisations of children and adults, in fact, due to pneumonia. So even in those settings, it still has an impact.
And is it major enough? Does it have side effects?
No, it's safe. Because I think Many countries here would be familiar with Haemophilus influenza conjugate vaccine. You know, same sort of profile. It's extremely safe. They're bacterial conjugate vaccines. You're not infecting somebody with the bacteria to get the response, such as some of the vaccines like a measles, where you give a low measles. It's not an active ingredient. It's just an antigen. So it's incredibly safe, and there's huge experience with it now. So, and there's been no problems.
But it's quite expensive.
Yeah. So some countries, that's what they apply to Gavi, and they'll have it subsidised through the EPI. The future is uncertain. You know, you can get 5 years support. What do you do then? Do you, as a country, take it over? But hopefully that funding will continue for the countries that can't afford it, that need it, so that every child can get it that needs it.
Leading from what she's saying, in Pakistan, pneumonia is the leading cause of infant mortality.
Sure.
And just recently, Gavi has supported us, as you're saying, to include it in the EPI program. I'm wondering why the other diseases have been given precedence or priority over this until now. This was not included. Is it because it's inexpensive?
No, it's because it was more recently developed. So the studies that show the effectiveness of pneumococcal conjugate vaccine have all been within the last 10 years. Whereas the studies that show...
Still, that's a long...
Yeah, but it does take time. I mean, first you've got to get the studies to show it was developed, and it started out as a 7-valent vaccine, which only covers 7 types of pneumococcus. Now, then it became a 9, then it became a 10, now it's a 13. And I think in terms of development from a new tool to getting it out there, it's done reasonably well. 1 decade, I think, is not too bad. Yeah, that has been a problem with pneumococcus. For Haemophilus, there is only one type of Haemophilus. For pneumococcus, there's 80 plus types of pneumococcus. And the vaccine's only good against the ones that it's made for. So they make it against the 13 most common causes of pneumococcal disease. Serotypes 1, 6, 3, whatever. Yeah. And that's been a challenge for pneumococcus. That hasn't been the case for measles or HIV or others as well. Just while I'm in Pakistan has also led the world in showing how you can manage child pneumonia at the community level with lady health workers in the community, that type of work, where they're out there in the community educating mothers, identifying pneumonia cases early and treating them with antibiotics in the community before they even have to get to a hospital. In fact, they don't get to a hospital. And the studies have shown that those children do very, very well.
So we talk a lot about generics in terms of like antibiotics and HIV medicine. Is that a thing in vaccines? Are there generic vaccines, and would that help to reduce the cost of something like?
Probably there isn't, and probably it would. Yeah, but no.
Is it more difficult to make a generic vaccine than a generic drug?
I'm not the expert on that,
Okay.
I'm sorry. But no, it's a very good point. Yeah, I'm not sure where things are at with generic vaccine manufacturing. Yeah, that's a good point.
Given who developed the pneumococcal vaccine, what company?
There's a number of companies doing it. They're all competing with each other, which is good to have competition.
Yeah, I was going to say give them a little time to get off patent to
Yeah.
recoup their investment.
Yeah, no, they're competing. I've got the 13, I've got the 10, I've just got, and
Right.
that competition has at least been good for keeping it down. But it's not cheap. But it's being subsidised in the high-burden settings.
Is there one more question before we close, or we cover everybody?
Yeah.
Pradeep, I knew you would have a question. Make it snappy.
Because I always ask questions. So just wanted to ask you a very simple question. What are the new drugs and diagnostic kits are developing for the pediatric TB? If you can at least give us a that.
Yeah, so new drugs are being developed for TB in adults and children. And the challenge in children is that simply once we get a new drug that looks like it's like bacterial, or there's others coming along that look like it's good for adults, we need to make sure we include children in the trials as quickly as as early as we possibly can. So we don't have this problem we've had in the past of just extrapolating everything from adult studies and applying it to children without really knowing what it does in children in terms of dosages and those sorts of things. Children generally tolerate drugs much better than adults, including TB drugs. They have less toxicity. That's a certainty. But it's in terms of what's the right dose for the little ones. That's an uncertainty. And so, you know, FDA and the European medical agencies, these groups encourage saying that you should include children in these new trials. And I just wanted to show very quickly, this is where we're sort of heading. I mean, experts are not going to bring much to improve the diagnosis of TB in children because you've still got to get the samples, and that's a challenge. And we're showing that it's not as good as culture. It'll only increase identification a bit more. But what people are trying to do is getting blood. What they're doing is they're getting blood from children, and then they're looking at, are there markers in the blood, comparing between a child who has TB disease, a child who has infection, a child who has neither infection or disease, and seeing if there are markers in the blood, such as this work being done in Melbourne, where you have different markers coming up for the child with active disease versus latent TB versus nothing. So if you can start to identify these markers and do all this fancy, they put them through these big machines that start to find things that indicate from the blood, that's what we're really aiming for. What we're aiming for is a point of care test, a blood test. Yes, no, this child, blood test negative, child does not have TB. Simple as that. That is what we need. The malaria's got it, HIV's got it, TB needs it.
Okay, thank you so much. This was terrific.
Well, I hope so.